Welcome to Lesson 3. In this session, we focus on a crucial aspect of long-term care: how to effectively monitor patients living with transthyretin cardiac amyloidosis. Once a diagnosis has been made and treatment initiated, consistent follow-up becomes essential to evaluate disease progression, monitor response to therapy, and adjust clinical strategies when needed. Monitoring therapeutic response remains a major unmet need in transthyretin cardiac amyloidosis. Because long-term clinical datasets are still limited, formal criteria for disease monitoring and progression were first proposed in 2021. These criteria outline 11 measurable parameters grouped across 3 domains: clinical and functional outcomes, biomarkers and lab tests, and finally, imaging and electrocardiographic findings. According to this model, progression is defined by deterioration in at least one marker from each of these 3 domains. Although these progression criteria have since been applied in tafamidis-treated patients, their reliability in assessing treatment failure or therapeutic benefit remains uncertain. More recently, a multi-center study proposed and validated 2 additional indicators of clinical worsening at the 1-year mark. These included an increase in NT-proBNP of more than 700 nanograms per litre and 30% from baseline, as well as intensification of outpatient diuretic therapy, both of which signal deteriorating cardiac function. In parallel, a single-center study involving over 1,100 patients identified a decline in 6-minute walk test distance by more than 35 meters, or 5%, as an independent predictor of increased mortality at 1 year. Despite these promising markers, none have yet been validated to guide therapeutic changes, highlighting the urgent need for robust tools to assess response and optimize treatment strategies. Although no randomized controlled trials have defined the optimal follow-up protocol, clinical consensus and expert recommendations support a structured and practical approach to monitoring disease progression, therapeutic efficacy, and emerging complications. For patients with diagnosed ATTR, both wild-type and hereditary forms, a widely adopted framework involves biannual evaluations. These include an electrocardiogram, ECG, and serum biomarkers such as NT-proBNP and troponin, which help track myocardial strain and injury over time. At the same 6-month intervals, patients should undergo a cardiology assessment, supported by imaging through echocardiography or cardiac magnetic resonance, CMR. These modalities enable visualization of changes in ventricular thickness, diastolic function, and other features indicative of disease progression. To monitor for subclinical arrhythmias or conduction system abnormalities, a 24-hour Holter ECG is recommended on an annual basis. In some cases, especially when therapy is ongoing, optional tools such as the 6-minute walk distance, 6MWD, and the Kansas City Cardiomyopathy Questionnaire, KCCQ, may be utilized to evaluate exercise tolerance and quality of life. For asymptomatic individuals with confirmed TTR mutations, a different monitoring cadence is suggested. Annual evaluations should include ECG, NT-proBNP, troponin, echocardiography, and comprehensive neurological and ophthalmologic assessments, as ATTR-V can affect the peripheral and autonomic nervous systems. Holter monitoring is generally conducted every 2 years in this population. Scintigraphy and CMR are reserved for patients who develop symptoms or have abnormal findings during routine testing, and are typically repeated every 3 years or as needed. Importantly, for ATTR-V carriers, follow-up should begin approximately 10 years before the expected age of disease onset in affected family members. This timeline may be further refined based on the specific genetic variant involved. This surveillance strategy provides clinicians with a flexible yet robust template for managing both symptomatic and asymptomatic patients. It emphasizes regular reassessment of cardiac function, biomarker trends, and rhythm stability, cornerstones in delivering high-quality, patient-centered care. In the next section, we'll explore how to evaluate disease progression and treatment response using a combination of imaging tools and laboratory parameters. Let's continue. Let's now shift our focus to the follow-up of mutation carriers and the role of genetic counseling. In patients with hereditary transthyretin amyloidosis, genetic testing is recommended for first-degree relatives. However, this should always be paired with comprehensive genetic counseling. The goal is to ensure individuals fully understand the implications of carrying a TTR mutation, including inheritance patterns and potential lifestyle or reproductive considerations. Because clinical onset typically occurs in adulthood, testing in children is not advised. That said, young adults may consider testing, especially if it can help inform life planning. The approach to follow-up must consider mutation-specific factors. Since disease onset and progression can vary, surveillance should begin around 10 years before the expected onset, based on the age at diagnosis in affected relatives or known genotype characteristics. If symptoms arise earlier, follow-up should begin immediately. Now take a look at Figure 1. It outlines a structured follow-up strategy for asymptomatic mutation carriers. The process starts with a baseline clinical evaluation a decade before the predicted age of symptom onset. At this stage, annual monitoring is initiated. This timeline is flexible. Patients with mutations linked to rapidly progressing forms of ATTR may need more frequent evaluations. Education is a key component. Carriers should be taught to recognize early symptoms that are specific to their mutation. If these signs appear, follow-up should be intensified. The aim here is to catch the earliest clinical manifestations of disease and to adapt monitoring to the individual's risk level. This proactive approach ensures that patients are not only tracked based on a generic timeline, but also according to their personal and familial risk profiles. Despite the existence of validated prognostic staging systems, tools to monitor disease progression over time remain limited. As new disease-modifying therapies continue to emerge, the development of more precise follow-up tools will be vital. Until then, structured, multidisciplinary surveillance remains the cornerstone for managing both diagnosed individuals and at-risk carriers. Imaging and treatment monitoring in ATTR cardiac amyloidosis. In recent years, our understanding of how imaging parameters reflect response to therapy in transthyretin cardiac amyloidosis has evolved. Most of this knowledge stems from Phase 3 randomized controlled trials, particularly those involving TTR stabilizers and RNA-targeted therapies. Currently, tafamidis remains the only approved transthyretin stabilizer for cardiac amyloidosis, while gene-silencing therapies such as patisiran and inotersen are approved for patients with hereditary transthyretin polyneuropathy, known as ATTR-V with neuropathy. However, because cardiac involvement often coexists in these patients, several subgroup analyses and retrospective studies have offered insights into the cardiac effects of these agents. One such therapy is diflunisal, a non-steroidal anti-inflammatory drug that binds to the thyroxine binding site of the TTR tetramer. It has shown efficacy in stabilizing TTR and slowing disease progression in patients with transthyretin-related familial amyloid polyneuropathy, ATTR-FAP. Retrospective studies have also linked diflunisal to improved survival in wild-type ATTR-CA. However, echocardiographic measures such as interventricular septal thickness and left ventricular ejection fraction did not show significant change with its use. When it comes to imaging-based monitoring, echocardiographic data are still somewhat limited. Yet, global longitudinal strain, GLS, and index stroke volume have emerged as the preferred non-invasive metrics for tracking disease progression and treatment response. In the landmark ATTR-ACT trial, tafamidis was shown to significantly reduce all-cause mortality and cardiovascular hospitalizations in a cohort of 441 patients. Importantly, a secondary analysis also revealed that the decline in stroke volume was slower in patients treated with tafamidis over a 30-month period. More recently, a retrospective echocardiographic study highlighted that tafamidis-treated patients showed significantly less deterioration in GLS over 12 months when compared to untreated matched controls. That same study also reported a smaller reduction in myocardial work index and efficiency, although no significant changes were seen in radial strain or ejection fraction. Other therapies, such as patisiran, have also demonstrated notable effects on cardiac structure and function. In an 18-month follow-up study, patients treated with patisiran exhibited improvements in GLS, left ventricular end diastolic diameter, and LV wall thickness when compared to untreated controls. Beyond echocardiography, cardiac magnetic resonance imaging, CMR, is playing an increasingly important role. One of the key CMR markers, extracellular volume, ECV, has shown responsiveness to therapy. In a study involving patisiran, a significant reduction in ECV was noted after 12 months of treatment, along with decreased uptake on DPD scintigraphy, indicating potential regression of amyloid burden. Let's take a moment to summarize these key imaging findings from clinical studies, as shown in Table 2. In echocardiography, stroke volume index declined more slowly with tafamidis use over 30 months. GLS and myocardial work index declined less rapidly in tafamidis-treated patients at 12 months compared with placebo. For patisiran, studies reported improved GLS, reduced left ventricular end diastolic dimension, LVEDD, and reduced wall thickness at 18 months. On CMR, extracellular volume declined after 12 months of patisiran therapy, with a corresponding reduction in DPD uptake, a marker of amyloid burden. In summary, imaging plays a critical role in monitoring therapeutic response and guiding ongoing treatment decisions in a ATTR-CM. While some metrics like ejection fraction may remain stable, parameters like GLS, myocardial work index, and ECV offer more nuanced insights into disease trajectory and response to therapy. Now that we've explored the broader landscape of imaging in ATTR-CM, let's take a closer look at echocardiography, a cornerstone of both diagnosis and longitudinal management. We begin with insights from the Apollo trial, which evaluated the RNA interference therapy patisiran in patients with hereditary transthyretin amyloid polyneuropathy, a TTR-VFAP. While the primary outcomes highlighted neurological benefits, a subgroup analysis of 126 patients with echocardiographic features suggestive of cardiac amyloidosis offered meaningful cardiac data. After 18 months, those receiving patisiran had a significant reduction in mean left ventricular or LV wall thickness with a p-value of 0.017. Moreover, 21.3% of patients in the treatment group showed an improvement in global longitudinal strain, GLS, exceeding -2% compared to only 8% in the placebo group, indicating a measurable reversal in strain abnormalities. In 2018, Garcia-Pavia et al. Released a consensus recommendation recognizing echocardiography as the first-line tool for disease surveillance in ATTR cardiac amyloidosis. They advocated for repeat imaging every 6 to 12 months, citing echocardiography's wide availability, relatively low cost, and diagnostic accuracy in resource-limited settings. While cardiac magnetic resonance imaging, CMR, holds promise, especially for tissue characterization, its routine use in long-term monitoring remains limited due to accessibility and cost. This figure visualizes the progressive changes seen in echocardiographic parameters and myocardial strain imaging throughout the course of a TTR cardiomyopathy. In the early stage, we observe mild LV wall thickening with preserved strain in the apical segments, a pattern often referred to as apical sparing. During the intermediate stage, wall thickness becomes more evident, and strain reduction spreads more diffusely, though still predominantly sparing the apex. By the advanced stage, there is marked concentric hypertrophy with near global impairment in strain values, including the apex. The bullseye plots below each echocardiogram illustrate this decline. The red areas represent preserved strain, while the pale pink and blue zones indicate progressively impaired myocardial deformation. This visualization underscores how GLS and segmental strain offer sensitive markers of disease progression, often before other parameters like ejection fraction are affected. Echocardiography plays a pivotal role across all stages of care, not just diagnosis. This is emphasized in the next visual. This schematic lays out the phases of clinical application for echocardiography in a ATTR-CM diagnostic phase. Echocardiography is often the first imaging modality to raise suspicion of cardiac amyloidosis. Common echocardiographic red flags include concentric or asymmetric LV wall thickening, disproportionate to blood pressure, restrictive diastolic filling patterns, biatrial enlargement. The hallmark apical sparing pattern seen on global longitudinal strain GLS bullseye maps. As shown in the left panel, Morphofunctional imaging and diastolic function analysis are key during this stage. When these features are observed, further confirmatory testing, such as serum and urine immunofixation, free light chain assays, or radionuclide scintigraphy, is typically warranted. Tertiary center follow-up phase. In specialized amyloidosis centers, advanced echocardiographic modalities like tissue Doppler imaging, TD1, and speckle tracking echocardiography, STE, allow for high-resolution tracking of myocardial strain, diastolic dysfunction, and changes in stroke volume and GLS. The middle panel of the figure shows how these tools help clinicians evaluate response to therapy and track subtle disease progression. Spoke center follow-up phase. Even in community-level or rural clinics, where advanced imaging tools might be unavailable, echocardiography remains a practical and accessible modality. The right panel of the figure shows how standard 2D and Doppler echo can evaluate volume status and congestion, monitor comorbidities like atrial fibrillation or aortic stenosis, guide diuretic therapy and timely specialist referral. In countries like Kenya, where tertiary imaging facilities are limited, this pragmatic use of echocardiography enables effective patient monitoring within local healthcare systems. Together, these applications emphasize that echocardiography is not only diagnostic, it's also a vital tool for longitudinal follow-up, helping detect deterioration early and evaluate the effectiveness of therapy. Now let's explore the evolving role of cardiac magnetic resonance imaging, CMR, in the assessment of transthyretin cardiac amyloidosis. In a prospective study by Fontana et al., published in 2021, researchers investigated the cardiac effects of patisiran in patients with ATTR-CM. This study included 16 participants and applied both CMR and 99 MTC-DPD scintigraphy over a 12-month follow-up period. The findings were compelling. The extracellular volume, ECV, a marker of myocardial amyloid burden, was significantly reduced in the treatment group by a mean of 6.2 percentage points. Importantly, 38% of treated patients experienced measurable regression in ECV, whereas none of the control patients showed similar changes. These results suggest that patisiran may contribute to cardiac amyloid regression. Moreover, DPD scintigraphy demonstrated a median 19.6% reduction in cardiac tracer uptake, further indicating therapeutic impact. However, it's important to recognize the limitations of radionuclide imaging in the follow-up setting. Variability in uptake in soft tissues and bones introduces significant interpretive challenges. As such, the study concluded that bone scintigraphy should remain limited to diagnostic use and not be employed for treatment monitoring. This aligns with expert consensus recommendations, which emphasize echocardiography for routine follow-up and advocate expanding the use of CMR in future clinical care pathways. In this image, we see a visual comparison of two ATTR-CM patients, one treated with patisiran, left panels, and one who received no targeted therapy, right panels. In the treated patient, baseline CMR reveals myocardial amyloid infiltration, illustrated by late gadolinium enhancement, LGE, and elevated extracellular volume. At 12 months, both LGE and ECV decrease, indicating regression of amyloid deposits. In contrast, the untreated patient shows worsening biventricular LGE and a continued rise in ECV, signaling ongoing disease progression. These side-by-side images clearly demonstrate how CMR can capture both structural improvement and deterioration over time. The normal ECV range, typically between 0.23 and 0.30, provides a valuable reference for interpretation. Nuclear imaging plays a crucial role in both the diagnosis and follow-up of transthyretin cardiac amyloidosis, specifically bone-seeking radiotracers like TC99M pyrophosphate, PYP. Nuclear imaging can be used to track the progression of a TTR-CM over time by assessing changes in tracer uptake in the heart. While more data is needed, nuclear imaging, particularly SPECT with quantitative analysis of tracer uptake, is being explored as a tool to assess the effectiveness of therapies aimed at reducing amyloid burden. Now let's take a closer look at this slide, which demonstrates the visualization of therapeutic response to RNA interference, or RNAi, treatment in a patient with hereditary transthyretin amyloid cardiomyopathy. In the upper panels, we see planar whole-body scintigraphy using technetium-99m labeled diphosphono-1, 2-propanoic carboxylic acid, or 99-MTC-DPD. These images are shown at baseline on the left and at follow-up on the right, after initiation of RNAi therapy. At baseline, there is intense cardiac uptake, which corresponds to Perugini grade 3, indicating a high burden of amyloid deposition in the heart. In contrast, the follow-up scan shows a notable reduction in tracer uptake, now consistent with Perugini grade 2, suggesting a positive therapeutic effect. Now, moving to the lower panels, we have quantitative SPECT-CT imaging also using 99-MTC-DPD. This modality provides more precise localization and measurement of the tracer concentration. Again, the left panel represents the baseline scan. Here, we observe intense radiotracer accumulation in the myocardium with a standardized uptake value peak, or SUV peak, of 7.48 grams per milliliter. This high value reflects substantial amyloid infiltration in the cardiac tissue. On the right, at follow-up, there is a marked decrease in radiotracer uptake, with the SUV peak reduced to 4.63 grams per milliliter. This reduction aligns with the planar scintigraphy findings and quantitatively confirms a therapeutic response to the RNAi treatment. In summary, this slide highlights how nuclear imaging techniques like planar scintigraphy and SPECT-CT not only allow us to detect cardiac amyloid deposition, but also to monitor the efficacy of targeted therapies like RNAi. The clear decline in tracer uptake demonstrates a biological response to treatment, a crucial metric in managing patients with ATTR-CM. In summary, CMR is emerging as a powerful tool for monitoring cardiac response to therapy in ATTR amyloidosis. It offers quantitative tissue characterization and can detect both improvement and progression, capabilities that go beyond traditional echocardiography. In the next module, we'll shift from clinical frameworks to real-world application through patient case studies.